The third component of Arkansas's Payment Improvement Initiative is an episodes of care model. With so much variation in the cost of performing common procedures and treatments, episodes of care offer the best opportunity for reinforcing best practices, resulting in improved quality and significant cost containment. This is designed to improve health outcomes and reduce inefficiencies when a patient needs a certain treatment for a condition, such as pregnancy, congestive heart failure, joint replacements, and other procedures or illnesses that require several resources that account for a large chunk of healthcare costs.
We all know that there's a lot of variation in the way physicians practice medicine. It's not necessarily good or bad, there's just a lot of variation. If narrowing that variation can help us reduce healthcare costs, and as we say, bend the cost curve over time, then I think everybody benefits.
Unlike other industries where more expensive products are typically higher quality, expensive healthcare services often don't mean better outcomes for patients.
Today in America, we pay too much for things that we shouldn't pay for in healthcare. There's too much waste in the system. And the model that Arkansas has developed, which is paying for valuable, effective, quality services that incents the providers to organize differently, will actually be transformative and be a lesson for the rest of the United States on how to change the healthcare system. We have providers that are primarily being paid on fee-for-service, on volume. And we're moving to a system where providers will be paid based on their quality. So by aligning and all payers paying from the same methodology, we will make it easier for the providers to understand what their objectives are that we want to achieve, which is higher quality and lower cost.
To help maintain high quality and establish acceptable cost levels, medical professionals and industry experts use real historical costs and evidence-based standards for appropriate care to determine an achievable cost range, called thresholds, for all of the care a patient receives within a certain period of time for each episode. For example, the pregnancy episode includes all treatments and prenatal visits, labor and delivery, and 2 months of follow-up care. For each episode of care, a principal accountable provider is designated as the quarterback for that episode. This provider is the main decision maker for most of the care provided during that episode and is in a position to coordinate that episode with other providers who may also see the patient during that time. Quarterly reports relative to each episode show how their performance compared to that of their peers, as well as establish quality standards. These reports help providers identify areas where they could make improvements.
This initiative would have never gotten anywhere without the capacity to crunch a lot of data. And so in order to make this work, we had to give providers a sense of where they've been and where they could go. And we're giving, in the episodes in medical homes, information that they've never seen before. Not only are they seeing what their practice is doing, they're seeing what their patients have had during the journey. So they're seeing what other providers have done in terms of spending resources to get outcomes while they've taken care of the patient. We're showing the doctors and the hospitals data that happens outside of their system so they can get a sense of what they might have to go and tackle. This is really something new. We're able to show them that compared to their peers, their patients are using more radiology, more ER, more pharmaceuticals. It gives people a chance to react to where they've been so that they can be potential winners in the future.
Providers share in the savings or excess cost of an episode, depending on their performance during each episode. Here's the breakdown. To use one type of episode of care as an example, let's say a patient goes in for a total knee replacement. As usual, the patient gives their insurance information and the facility then files the insurance claim. Then, information about quality and cost of care for that knee replacement is summarized and transferred into a provider portal that can be accessed online. Here, providers can view reports that show the overall quality of the treatment and the average cost for all of the hip replacements they perform. The provider reports also include information for all of the other types of episodes for which they are accountable.
Let's say this provider's average cost for a knee replacement is $18,000 for all associated charges, including hospital, physician services, the cost of the replacement knee, lab fees, etc. For each type of episode, historical costs in Arkansas and standard best practices have been analyzed. Appropriate and realistic cost thresholds for each type of episode have been agreed on and set, ranging from acceptable to commendable. The provider's average cost of $18,000 for a knee replacement is compared to the set thresholds. If a provider's average cost is above the acceptable level, the health provider will pay back a portion of the excess cost. If the final cost is below the acceptable level, or commendable, and the provider has met or exceeded quality standards for the episode, he or she is rewarded with a portion of those savings. This system provides a significant incentive for medical professionals to manage the quality of care their patients receive and to monitor costs that they may otherwise not have paid attention to. Let's do the math. At the end of the year, the provider has performed 10 knee replacements at an average cost of $18,000 and has met quality standards. If the commendable cost threshold was set at $19,000, then the provider would have saved $1,000 on average for 10 episodes, or $10,000 total. This provider may then be reimbursed with up to 50% of these savings, or $5,000 for that period.
So we've designed this program where 80% of providers, hospitals and doctors, are either going to be winners or revenue neutral. The better clinical doctors bought into this immediately, realizing that they could be winners in this program, that they could take higher risk patients, get better outcomes, and for a change, get paid more.